Okay, so endocrine pharmacology is a relatively small section. There really isn't anything too crazy about it. It's still a very important segment, though. You definitely need to know the management of diabetes the best you can, right? So it's really important to really understand not just diabetes management in terms of medications, but also what it is you'd be telling your patients to do when the medications alone aren't enough to help them. So make sure that you really know the different classes of drugs for diabetes and each of their mechanism of actions and their various side effects, because the way you get tested on these questions is usually going to involve some level of like description by the question itself, telling you, someone's taking a certain medication, this is the mechanism it works with, what medication is it, or they might give you the mechanism it works with, and then they'll ask you what's a potential side effect you have to watch out for. So stuff like that. So at the beginning right here, I have like a basic description of stuff that's related to each one, right? So you have diabetes type 1, type 2, and gestational. The primary way of kind of dealing with each one. So remember, type 1 we said is kind of like primary diabetes, right? So the issue with type 1 is that these people don't have insulin secretion, right? Because the beta cells have been destroyed by the glutamate decarboxylase antibodies. So now you need to give them insulin replacement, and you have to put them on a low carb diet, because in type 1 diabetes they're very sensitive to both insulin as well as glucose intake. In type 2 diabetes, which is secondary, they're able to make some level of insulin, right? The issue with them is insulin resistance. Their body doesn't exactly utilize the insulin, so these people end up gaining weight, right? Because they're gonna keep releasing insulin and more insulin and more insulin, but the insulin isn't exactly getting to the cells and the targets it needs to, and it's not really doing its job. But insulin is anabolic by default, and everything it does makes you gain weight. So you tell these people to diet and try losing weight by exercising, right? Things that can further help the effects of insulin take place. Gestational diabetes is very much managed similarly to diabetes type 2, so you just have them have a controlled diet and exercise as well. And usually gestational diabetes will fix itself as soon as pregnancy is done. So if we take a look at all three, the book tells you about it too. So all patients with diabetes should have education on diet, exercise, blood glucose monitoring, and complication management. And this education is the number one thing we're all supposed to do as physicians. This is the part that a lot of doctors these days tend to miss out on. It doesn't matter how much your patient doesn't really want to hear about it. That's not the point. You have to give them that education. You have to tell them they need to hear about it, or they're going to die. Diabetes does kill people, right? The only reason everyone with diabetes isn't dying is because we've learned how to manage it. We've learned how to treat it. There's no cure, but we can manage the things that we need to do. So you have to educate people on what they should be eating and what they should not be eating, how they should be eating, what are actual diet plans that they can try following to better improve their diabetic condition. Exercise, and not just say, hey, go work out, but tell them exactly what it is they can do, right? 10 minutes on the treadmill, 20 minutes on treadmill every day is a big deal compared to nothing every day, right? Walking around the block, going for a walk at the park, and depending on how fit and what the age of the patient is, you could tell them go running, lift weights, do aerobic exercises at home, whatever it might be. And then obviously very important to tell them to monitor their blood glucose, especially in the beginning when you put them on new medications. They have to see how they're responding to the medication, whether the medication is too much for them and their glucose is too low in the morning when they wake up, or if it's not enough, right? And then glycemic control, right? This is also a new thing that's starting to pick up a lot now that the keto diet is a big deal. A lot of foods are going to be sugar-free or low glucose or whatever, but what you really need to figure out is what is the glycemic index of that food, right? A lot of foods that are quote-unquote sugar-free have a high glycemic index, or some foods that don't really have much sugar in them to begin with and aren't colloquially known to be like, oh, that's a bad thing to eat because you're diabetic, you shouldn't eat it. A lot of those foods actually have a very high glycemic index, and that's the reason you're not supposed to be eating them, not because they have high sugar or something. So glycemic index is something you want to explain to your patient and really have them understand as well. And what I believe all clinics and hospitals should be doing is giving out a booklet of some sort that really educates the patient, right? So that even if the patient himself isn't really able to read or write, someone in their house, someone that they know can look more into it for them, okay? And then, of course, with type 1 diabetes, all you can do is replace the insulin because they can't make it. In type 2, you give them oral agents, metformin. Every type 2 diabetic generally takes metformin at some point in their life. Non-insulin injectables, right? They have to take medications that they have to inject themselves with stuff, but it's not an insulin injection, and we're going to see that. And then insulin replacement if necessary, and the most important part, weight loss, okay? Gestational diabetes is just insulin replacement if the nutrition therapy and exercise alone fail. So regular or short-acting insulin is preferred for DKA, right, diabetic ketoacidosis. So just do IV regular short-acting insulin for diabetic ketoacidosis patients, hyperkalemia, and stress hyperglycemia. All right, those are all the cases where you just give regular short-acting insulin. For the hyperkalemia patients, also give them glucose, and that's generally all there is. Now, what I have written over here are the G protein coupled receptors on pancreatic beta cells, right? All the way from the beginning where you, when you go to pharmacology, autonomic drugs, right? Remember that M3 uses GQ, glucagon uses GS or GQ to increase insulin. What am I saying? Oh, just the glucagon itself is GSGQ. Increased insulin secretion. And over here you have your beta 2 and GLP-1, which use GS. All right. So all of these are things that are actually mentioned back here. Let's kind of go back to that autonomic drugs. You go down to this spot right here, and you can see the insulin release stuff, right? So M3 uses GQ for increasing insulin release, right? And over here, beta 2 uses GS for increasing insulin release. Alpha 2 decreases everything, so that's already a known factor. And that's generally it for that aspect. So when we go back to endocrine pharmacology, that's what I've basically written here, right? So remember the G proteins. So M3, GQ, and beta 2, all of these guys on the right side, M3 and beta 2, therefore increase insulin secretion, whereas glucagon uses GS and GQ. Alpha 2 and somatostatin both use GI and decrease insulin secretion. So that part is also something we will see more of when we get into gastrointestinal. So know the receptors, because they can pop up, and they're not that hard to know. They're really not that hard to know. So first thing we look at are your injectable medications, right? So you have your insulin preparations. They're all going to vary like this chart based off of how long their effects last. Glargine being the longest lasting. As you can see, it has yet to come back down. Amylin analogs and GLP-1 analogs. GLP-1 analogs are great, but let's go in order. So, all right, insulin preparations. So Lispro, Aspart, and Glulisine have no lag because they're rapid acting. Short acting is just a regular one, and intermediate acting is NPH. The long acting insulin are Detamir and Glargine, and that's all you really have to remember, Detamir and Glargine, because the others kind of fall into place. If you look at the NCLEX, the exam that nurses have to give, they actually need to know the how long these insulins actually last for, how long their effects last for. And it's here in first aid for us as well. We also need to know. Although not commonly seen in our exam on step 1 in NBME, you can be given a question where someone is being given intermediate acting NPH, and then they're going to ask you how long is it going to take for that medication to finally, not be having any effects. And you have to remember it can take up to 10 hours. So that's something that the NCLEX actually test people on, but it's here for us, so we should know it too. We should definitely know it because it's going to be something that when you get into practice later on, nurses are going to be working with you and you're going to be telling them what to do and stuff, and you have to be able to speak about the hours correctly. All right, but these are all just basically different variations of insulin. So they all bind the insulin receptor, which uses the tyrosine kinase activity as we've been seeing so far. In the liver, insulin does the same thing everywhere. Like, doesn't matter what, all insulins do the same thing. So basically, increase glucose storage, that's glycogen. So you're making more glycogen now, glycogenesis, right? Muscle, increase glycogen and protein synthesis. And then in fat, increase triglyceride storage. And in the cell membrane, potassium uptake. Right? This is the basic activity insulin always does. Adverse effects of these injections can basically be the hypoglycemia, which is why in the beginning these patients are always going to need to be monitoring their own glucose. And you can have lipodystrophy and hypersensitivity reactions, but generally speaking, the most common thing you'll see is the hypoglycemia and the weight gain. Right, the weight gain is going to be always a thing because insulin by default is anabolic. Alright, so that's what we're seeing on this graph. You can see Lispro and Aspart work for about, maximum their effect is lasting about 3 hours. Right, then it starts to peak down very quickly. Regular goes up to like 6 to 7 hours, and you have your NPH, which has an effect at up to 10 hours. Later on, it's just too low. Detemir and glargine are the longest acting, up to 18 to 24 hours. Then we have our amylin analogs. So there's only one medication so far here, which is pramlintide, which has the amylin in the name. All right, so pramlintide, amylin analogs work on the pancreas and the pylorus of your stomach. It slows down glucose spike after a meal and is great for diabetes type 1 as well as type 2 because the slowing down of blunted glucose is always going to be a nice thing, right? So you don't want glucose to be too high after eating in patients. And it's also great because of what it really does. It increases satiety, so you're not going to overeat. It slows down gastric emptying, and it decreases glucagon release, right? This is always, you never use this alone. It's always going to be in combination with insulin therapy. And, of course, the only side effect it can have is hypoglycemia, especially if you have mistimed prandial insulin, which means if you took insulin but you didn't eat, or if you didn't eat and you took insulin, well, that was the same thing. So basically, anytime you have a case scenario where you were supposed to eat but you didn't, yet you already took your insulin, you're going to end up having hypoglycemia now, all right? So once you've taken the insulin, you have to eat no matter what. So don't do it if you're not about to eat. GLP-1 analogs are starting to become more popular now. I've been taking my mom. She's diabetic. I've been taking my mom for a lot of endocrinologist visits lately, and GLP-1 analogs are something that endocrinologist put my mom on as well. So definitely a great medication because the doctor was really talking about it a lot. Right, so exenatide and liraglutide. These guys also decrease glucagon release, also decrease gastric emptying, but they, more importantly, increase GIP release, right? Glucose-dependent insulin release. So the effect of promoting weight loss is the part that's the best thing. Right, that's very important. And then, of course, it increases satiety, so you're not really going to be that hungry. And the only potential bad side effect it can have is pancreatitis, but it's very rare. It can't really occur. All right, so hopefully it won't, but it's a very rare side effect. And I was reading articles about it online, and I think it said about 2% of patients have had pancreatitis, but even in those percentages, in those 2% of people, they weren't exactly sure if it was the medication itself or some other reason that led to the pancreatitis. All right, so that's that. Then you have your oral drugs. So that's it for your injectables. There's nothing else. Now you just have your oral drugs: biguanides, sulfonylureas, and meglitinides. There's many more, but this page only has these so far. So you definitely want to make sure you know biguanides, right? Because that's just metformin. And as we just said, all type 2 diabetics are going to be taking it. Inhibit hepatic gluconeogenesis and the action of glucagon by inhibiting MGPD, which almost no medical student really knows much about. Right? It increases glycolysis and peripheral glucose uptake, so you have more insulin sensitivity, which is great for type 2 diabetics because they have decreased insulin sensitivity. Side effects include an upset GI, lactic acidosis, and B12 deficiency, of which I've really seen B12 deficiency being tested. Promotes weight loss, which is often desired, and that's great too. So what is MGPD? MGPD is mitochondrial glycerophosphate dehydrogenase. That's what the little m stood for. And glycerophosphate dehydrogenase inhibition reduces the conversion of lactate and glycerol to glucose and reduces hepatic gluconeogenesis. Man, this guy. I don't know how long a lot of you guys that are watching my videos have known me, but I first started last year in January. And this psychopath that lives next door to me has actually been using a saw machine to cut wood and build little wooden houses in his backyard for all that time. In some of my very first biochemistry videos from way back last year, January, he's there too. He's making the same sounds, they're obnoxiously loud. And he actually is a psychopath, so it's very unfortunate that he's my neighbor. But yeah, mitochondrial glycerophosphate dehydrogenase. Right, so you inhibit that. You stop the lactic acidosis aspect, right? Conversion of lactate and glycerol to glucose. Sorry, you cause the lactic acidosis aspect because of that, right? So because you're no longer going to convert lactate and glycerol into glucose. So you reduce the hepatogluconeogenesis, which is fine for diabetic patients, but you can possibly get lactic acidosis, all right? It doesn't really happen as much. I've never really seen it being tested, but I have seen B12 deficiency being tested, all right? Sulfonylurea, so there's the first generation and the second. The second generation are the more commonly used, like glyburide, glipizide, and glimepiride. First generation, chlorpromide and tolbutamide. Overall, the sulfonylureas aren't that commonly used, but if they are, it's usually going to be a second generation one. All right, so the Tide medications, the one that end in Tide, none of them end in Tide, right, Tide. I think I meant just the IDE, the IDE medications. Slow down oh, okay, I see what I'm trying to do here. Although it is I wrote Tide, but we'll get to it. So basically what I wrote here is that the Tide medications slow down the Tide, which is like a water tide, decrease glucagon and gastric emptying, plus more weight loss, while the Ride, Mide, and Nide medications increase endogenous insulin release and cause weight gain. We're going to see some of them are Tide, like we're going to see right here. Where was it? I think it was up here, wasn't it? Where's the... Yeah, these two guys, exenatide and liraglutide, right? So those two Tide medications, this is just a memorization thing. I'm going to come back to it. It's going to be a little confusing right now. I don't know why I put it in the middle of here, but this is just a memorization tool to really help you understand what all the different medications kind of do. So since I've already spoken about it, basically all the medications that end in Tide, like exenatide and liraglutide, they slow down the Tide. So they decrease glucagon release and they decrease gastric emptying, leading to weight loss. While the Ride, Mide, and Nide medications, like over here, we have our chlorpromide and tolbutamide. Right, these guys increase endogenous insulin release and cause weight gain, which is why they're not really used. Right, sulfonylureas are not a preferred group of medications by doctors. So what they do is they go ahead and directly close potassium channels in the pancreatic beta cell, which leads to the cell depolarization and insulin release. Right. Remember that originally the potassium channels would only close because you had glycolysis inside the beta cell, which made more ATP, and the elevation in ATP would close the potassium channel. But you don't have that here. You just end up using sulfonylureas to do it. Right? So you get more calcium influx, leading to insulin release. So you can obviously get hypoglycemia, weight gain. The first generation ones also have a disulfiram-like reaction, while the second generation ones just have hypoglycemia. The issue here was increased risk with renal failure, so you can't even give it to patients who have renal failure. And that's another thing you have to watch out for because that's a very test-worthy topic, right? So a patient that comes in with renal failure and needs new diabetic medications, you don't give them sulfonylureas. And I always remember the renal aspect of sulfonylureas as well as meglitinides because the name has urea in it. So, I just use that to remember the fact that I can't give it to someone with renal failure. So these two are your mides, and then you have your rides as well, right? The rides, which is the glyburide, Zide, whatever it might be, any other IDE besides Tide. These guys all cause you to gain weight, right? Even the meglitinides, netiglinide and rapaglinide, they all work the same way as well. We'll come back to this question. Let's just keep going to the oral drugs first. So now another pretty interesting group of medications are your DPP-4 inhibitors. These are also less commonly used, mainly because insurance companies don't pay for the medication, right? But what this does, linagliptin, saxagliptin, and sitagliptin, these guys inhibit DPP-4, which then stops you from deactivating your own GLP-1. See, DPP-4 is an enzyme that actually stops GLP-1 from doing its job, and you want GLP-1 activity, right? Because even look at this medication up here, right? We are giving GLP-1 analogs to help. So you want GLP-1 activity, and if you stop the enzyme that kills GLP-1, you're basically going to get the same effects again: decreased glucagon release, decreased gastric emptying, increased GIP, and satiety. Right, so it works. So these gliptin medications work just like GLP-1 analogs up here. So you can see mild urinary or respiratory infections as one of the side effects, and weight neutral. Right, so this mild urinary or respiratory infection is something really hard to remember. I've never really seen it being questioned, but it's definitely very hard to remember, because you're not really going to associate a diabetes medication with infections of this type. Many people we always associate diabetes medications with UTIs, but only this one, only the SGLT2 one, which actually causes you to pee out more sugar. But DPP4 inhibitors don't do that. They don't make you pee out more sugar, right? So I wrote here, gliptins lead to GLP increase, which really helps remember what the activity of it is. But other than that, it's a pretty easy medication to remember. Glitazones and thiazolidinediones, right? So I always say glitazones break bones. Glitazones break bones because they actually do have an increased risk of fractures. So you have to keep in mind, if you have the question, like, remember, because of the Beers criteria, you have to remember that if you ever get a question on a patient who is elderly, you don't give them glitazones, right? Because the elderly patient already have increased risk of fractures. Postmenopausal women already have increased risk of fractures. You don't want to give them any of these medications like pioglitazone or rosiglitazone. So what do these guys do? They activate PPAR gamma, which is very easy to confuse with the cardiovascular medication we saw, fibrates. Fibrates activate PPAR alpha, and you're supposed to remember that because it also deactivates 1-alpha hydroxylase and has a risk of causing gallstones, right? So that's something fibrates do. Glitazones work with PPAR gamma, which is a nuclear receptor, leading to increased insulin sensitivity and levels of adiponectin. That leads to regulation of glucose metabolism and fatty acid storage. However, anytime you increase insulin sensitivity and the levels of adiponectin itself, you're going to have weight gain. All right. So not exactly a preferred medication. Once again, adiponectin is a cytokine secreted by fat tissue. It increases the number of insulin-responsive adipocytes and stimulates fatty acid oxidation. Thiazolidinediones decrease TNF-alpha and leptin production. Low leptin equals low satiety, so you're always going to be eating, leading to weight gain. All right, so pretty problematic medication. Not exactly sure why or when you would ever give it to anyone, but it exists. SGLT2 inhibitors are short-term use, as far as I can tell. You give this medication to patients who have very high glucose levels and very bad A1C. It blocks the reabsorption of glucose in the proximal convoluted tubule. So you pee it all out, right? So glucosuria, UTIs, vaginal yeast infections, hyperkalemia, dehydration, and weight loss are all things you can note with SGLT2 inhibitors. Not recommended if kidney function is impaired, right? Because this medication obviously works with the kidney. This is actually the only drug that doesn't act on the GIT. It works at the kidney to let all the glucose out. Avoid in patients with moderate or severe renal impairment. Check BUN and creatinine. Bacteria and fungi love sugar though, so you get yeast infections along the urinary tract. The Flozin medications cause glucose and weight loss to flow in urine. All right. Really, I was just supposed to write glucose to flow in your urine, but the weight loss part was important too. So another memorization tool. Last oral drug is your alpha-glucosidase inhibitors, acarbose and miglatol. They also do a similar thing to SGLT2, but they obviously work in the GI. SGLT2 is the only one that works in the kidney. Alpha-glucosidase inhibitors inhibit intestinal brush border alpha-glucosidases, leading to delayed carbohydrate hydrolysis and glucose absorption. So you have decreased postprandial hyperglycemia, right? Everyone has higher sugar after eating, but not patients who are taking one of these medications, right? Again, not recommended if kidney function is impaired. Almost all of these medications can't really be given to someone with impaired kidney function, so you gotta watch out for that, right? The DPP4 inhibitors are fine in impaired kidney function, and let's see. And that's really it, yeah, for oral drugs. Everyone else you have to watch out. See, used with caution in renal insufficiency, increased risk with renal failure for hypoglycemia. This one is okay. Here, increased, what is this one? Oh, the pioglitazones, they're okay to use with renal failure as well, but again, bad medication in general with the increased weight gain and risk of fractures. So there's that. But you can give these two guys. These two guys you can give to people with impaired renal function, and that's it. That's the only two. All right. So let's take a look at this question on this page right here. So a 43-year-old woman comes to the office due to episodic confusion, blurred vision, tremors, and sweating. Symptoms have increased in intensity in the past few months, and the episodes occur any time during the day, but are relieved by drinking orange juice. Past medical history includes major depression and irritable bowel syndrome. Lab studies show episodes occur anytime during the day but are relieved by drinking orange juice. Past medical history includes major depression. Sorry, did I just read something wrong? My bad. Blurred vision, tremor, sweating. The symptoms have increased in intensity in the past few months, and the episodes occur anytime but are relieved by orange juice. Okay, past medical history includes major depression and IBS. Lab studies show a low glucose, that's extremely low. Insulin is super high. C-peptide is also very high. Which of the following is the most likely cause of the patient's hypoglycemia? Well, this actually looks like she has... Okay, I see. You could think of it as an insulinoma or something that's causing her to release a lot of insulin, right? Because her insulin went up and her C-peptide also went up. So she's not injecting herself with insulin. And if you look at all the answer choices, picking sulfonylurea use is the best way to go because sulfonylurea makes you release your own insulin, right? Symptomatic hypoglycemia is confirmed by Whipple's triad, where symptoms of hypoglycemia are present and you have low blood glucose, but everything gets fixed up after you get some juice. Elevated insulin with undetectable C-peptide will tell you that she's injecting a lot of insulin, exogenous insulin, but if you have an elevation in both insulin and C-peptide, then that might be endogenous insulin from some insulinoma, or sulfonylurea, meglitide, or any of these other medications, these two groups right here, that cause you to release more insulin yourself. Okay? And this is typically seen in healthcare workers and family members of diabetic patients, usually associated with depression or personality disorders. Right? Someone that's just looking to be catered to, someone that just wants attention, etc., etc. Alright, so that's what we're seeing here with that patient. So really careful and really cool thing to watch out for, right? You're going to see increased insulin and C-peptide in the patients taking one of these guys, sulfonylureas or meglitinides, because you actually end up releasing more insulin yourself. Now, the rest of this are different medications for different things in endocrine pathology. So thionamides like propylthiouracil and methimazole are actually pretty high-yield medications related to the thyroid. They block thyroid peroxidase and they inhibit the oxidation of iodide as well as the organification and coupling of iodine, leading to the inhibition of thyroid hormone synthesis. So you would obviously use this in cases of hyperthyroidism. PTU also blocks 5'-deiodinase, which decreases peripheral conversion of T4 to T3. Now, PTU is used in the first trimester in pregnancy because methimazole is teratogenic. You cannot give methimazole to someone who is newly pregnant, right? You can't use methimazole in the first trimester. However, methimazole used in the second and third trimester of pregnancy due to risk of PTU-induced hepatotoxicity. Right, so there's a very intricate thing here. So you use PTU the first trimester, and then you use methimazole the second and third trimester. Right, you can't use one medication throughout the whole pregnancy, though, because if you keep using PTU, PTU causes hepatotoxicity. Now, it's used in hyperthyroidism, but it's not used to treat Graves' ophthalmopathy. Right, you have to treat the ophthalmopathy with corticosteroids, because remember, the ophthalmopathy and even the pretibial mixed edema was all due to the antibodies itself upregulating fibroblast activity and depositing more glycosaminoglycans, right? So you can always get that one weird question where a patient with Graves' disease comes in and you gave them one of these things, the propylthiouracil, methimazole, but what won't be fixed is going to be the question, and you have to pick the one thing or whatever answer choice is there that requires prednisone to be treated. Now, adverse effects of propylthiouracil and methimazole include skin rash, agranulocytosis, aplastic anemia, something really bad that you wouldn't want to occur to your fetus. Right? Just think of something like that, and that's really all there is. Nothing very specific to it, though. Levothyroxine and liothyronine. Now, everyone uses levothyroxine because you don't want to ingest T3. Remember, T3 is active. T4 is inactive, so you're basically giving your body a bunch of T4 and letting your body decide how much of it becomes active. This is just for thyroid hormone replacement. Clinical use, hypothyroidism, and the mixed edema may be abused for weight loss, but that's a terrible idea because you're going to end up messing up your entire hypothalamic pituitary thyroid axis. Distinguish exogenous hyperthyroidism from endogenous hyperthyroidism using a combination of TSH receptor antibodies, radioactive iodine uptake, and or measurement of the thyroid blood flow on ultrasound. Of course, if someone has high thyroid levels and very low TSH, that means that they've been eating a lot of thyroid, because it definitely isn't the TSH that's telling them to make it. All right. Let's take a look at these two questions now. So the first one, 28-year-old woman comes to the office due to progressively worsening eye irritation and double vision over the last 2 months. She also reports unintentional weight loss, mood swings, and palpitations. The patient has no prior medical problems and takes no medications, nor does she have drug allergies or use tobacco, alcohol, or illicit drugs. Great. What an excellent person. Blood pressure is 140/70, pulse is 100 per minute, and regular. Physical exam shows bilateral conjunctival redness and severe proptosis, right? So her eyes are popping out. Appropriate therapy is begun, and 4 weeks later, her eye symptoms have improved, and examination shows a small decrease in proptosis with no redness. The drug that improved her ocular symptoms most likely did so by affecting what? And it affected the inflammatory infiltration. This patient has Graves' disease with hyperthyroidism, which is an autoimmune disorder triggered by thyrotropin receptor antibodies that bind and activate the TSH receptor. Graves' ophthalmopathy is caused by stimulation of orbital fibroblasts by the thyrotropin receptor antibodies, ultimately leading to inflammatory infiltration by T cells. Glucocorticoids decrease peripheral conversion of T4 to T3, but it is their anti-inflammatory effect that improves the Graves' ophthalmopathy. All right. So that's one thing, that's great. Then the next one, 21-year-old man comes to the emergency department due to several days of dizziness and extreme fatigue. He has been drinking a lot of water and urinating more than usual for the past 2 weeks. He developed nausea and vomiting a day ago and has had difficulty keeping foods and liquids down. The patient has no other medical problems and takes no medications. Doesn't do drugs or anything. Blood pressure is low, pulse is high, respiratory rate is 22. His urine is positive for glucose and ketones, right? So that's a type 1 diabetic right there. He started on IV fluids and IV infusion of recombinant human insulin without any amino acid modification. The same type of insulin will be used subcutaneously in the long-term management of this patient. What drug curve will be obtained after administration of this insulin? And the answer for this was the red curve from the graph above. So if you look at the graph above, oh, right, I forgot. Let me go back to that because so I removed the picture because they put their own picture now at First Aid 2019. So let's take a look at that in First Aid 2018. Pharmacology. This curve, you see the red line, right? So if we come down to here, yeah, this question. Okay, so this is the same image but from UWorld itself, and then they pretty much took this image and put it into First Aid 2019 now. So it would be this curve, so just regular insulin, right? If you take regular insulin and add an amino acid group to it or whatever, then it becomes NPH. It basically slows down how quickly it gets digested and used. So that's what this question is all about, right? So they tell you that he started on IV fluids and IV infusion of a recombinant human insulin without any amino acid modification. No amino acid modification. The same type of insulin will be used subcutaneously in long-term management. And that answer is the red curve, which is just regular insulin. The patient's vomiting, volume depletion, glycosuria, and ketonuria are consistent with diabetic ketoacidosis. DKA requires IV regular insulin, which begins to lower serum glucose and ketone levels within minutes of administration. And you're just supposed to know that, right? Because they just told you that in the beginning as well. Right here, that regular insulin is preferred for DKA, and regular insulin is the blue curve here. So I'll change that in the text downstairs, right? This blue curve. So any question you get where these curves were given, you could have easily just chosen that curve from the graph and you would get the question correct. All right? Let me just see the blue curve. 1, 2, 3. Okay. Blue curve. Regular insulin and NPH are the only human recombinant insulin without any amino acid modifications. Insulin lispro, aspart, and glulicine are rapid-acting analogs. Due to various amino acid modifications, they do not polymerize into hexamers like regular insulin, allowing them to have an onset of action in about 15 minutes. Detamir is a long-acting insulin analog with a fatty acid bound to one of the lysine residues, allowing detamir to bind to albumin and slowly dissociate. So that's how detamir acts for a long time. Glargine has a pH of 4 and forms a microprecipitate in the subcutaneous tissue after injection, resulting in slow release. Right? So such intelligent pharmacology right there, where pharmacologists were able to make medications that would find a way to become slow release. All right? And do you need to know this? Well, not necessarily, but UWorld did teach it, and you can definitely get a question on it on an NBME. But I've never really seen a question about any of this ever before, right? But I still do try my best to remember it. So detamere is the one with the fatty acid associated to it, whereas glargine has a pH of 4, so it just makes it precipitate. And those are the reasons why these two guys are very long-acting. That's how they become slow release. Rest of these, so hypothalamic pituitary drugs, we talked about ADH antagonists, which you would use for SIADH, right? So they have that tan ending for antagonist, conivaptan, tolvaptan. The VAP is vasopressin, right? So vasopressin antagonists. And that's basically all that's happening there. Desmopressin is used for central DI, but later on in hem-onc we'll also see it's used for von Willebrand disease because in blood vessels it causes you to release factor 8, and factor 8 carries von Willebrand disease. The other way around, it causes you to release von Willebrand from your blood vessels, and it carries factor 8. Because von Willebrand is actually in your blood vessels too. It's in the endothelium. So desmopressin makes you release it. Desmopressin is also preferred for sleep enuresis because it's the better medication compared to the other stuff. The desmopressin doesn't have bad side effects, and you can use it for hemophilia A, where you're missing factor 8, right? So again, desmopressin makes you release von Willebrand from your endothelium, and that von Willebrand has factor 8 in it. Okay, so that's why you can use desmopressin for all 4 of these issues. Growth hormone for anyone with growth hormone deficiency or Turner syndrome. Oxytocin for labor induction, and as well for uterine hemorrhage afterwards. And somatostatin for a bunch of stuff, right? Anywhere where you have too much release of any kind of weird hormone, somatostatin makes it stable, and the whole thing becomes static. Demeclocycline, which is actually a tetracycline, right? So it does cause the abnormality, the yellow coloring of teeth. Was actually an antibiotic, but it no longer gets used in that manner. Now it's also considered an ADH antagonist. So again, you would use it for SIADH. Fludrocortisone, very commonly used, is ascending in SON, or it's a cortisone, so you already can tell it's a glucocorticoid, but it's an interesting one. This synthetic analog of aldosterone with little glucocorticoid effect. Mineralocorticoid replacement in primary adrenal insufficiency, right? Fludrocortisone. So this is actually more like an aldosterone than it is a glucocorticoid. Cinacalcet sensitizes calcium sensing receptors in parathyroid gland to circulating calcium, thereby reducing PTH. So you would use this in any disease where you're not really very sensitive to the calcium around you. And we saw that with our familial hypocalciuric hypercalcemia, that one. Right, so that's where you would use this basically. And they also tell you to use it in any case of secondary hyperparathyroidism, hypercalcemia, and primary hyperparathyroidism. Right, all of these are fine places to use it in. And that's generally all cinacalcet is for. The last thing here is sevelamer, is also a really good medication. It's a non-absorbable phosphate binder that prevents phosphate absorption from the GIT. So you would just use this to to fix the hyperphosphatemia in chronic kidney disease. Why would you want to fix hyperphosphatemia? Well, basically, if you have high amounts of phosphate, that also causes you to release more PTH. Remember, PTH is affected by multiple things. So if you have high phosphate, low calcium, low magnesium, you're going to release more PTH. But if you have significantly low magnesium, then you're going to have no PTH. Right? So that's how PTH is regulated. So you definitely want to make sure that in chronic kidney disease patients, you don't end up having hyperphosphatemia for some reason. Now to end it all up, we have one last AMBOSS question. 57-year-old woman with type 2 diabetes mellitus comes to the physician for a follow-up exam. She previously had been compliant with her diet and medication, but has had 11 pounds weight gain since the last visit 6 months ago. She reports that she often misses doses of her metformin. Her A1C is 9.8, which is very high. Which of the following is the most appropriate course of action? Schedule more frequent follow-up visits. And that's what you're supposed to pick. And there's a very specific reason you pick this for. You can't try scheduling more follow-up visits with a patient who's younger. Right? Someone who's in their 35 to 40 area is going to have work, is going to have family to deal with, a lot of things to do. It's very hard to get them to do it, but it's probably the correct answer for them as well. But at age 57, you're much more capable of coming in for frequent follow-up visits, and you have to do it because you need to keep getting those follow-up visits happening until the A1C comes down to closer to 7% and hopefully around 6.5 if possible. All right, the poor medication adherence is the most likely cause of her poorly controlled diabetes, but the cause of her non-adherence is unclear at this point. Scheduling frequent follow-up visits, providing written instructions, employing a patient-centered approach, and optimizing the treatment plan, like prescribing once a day scheduled medications when possible, are all important strategies that should be considered to improve medication adherence and to establish a stronger doctor-patient relationship. Frequent follow-up visits also enable closer monitoring of the patient's medication use. All right, so very important to remember this for step one, because step one really loves working on that doctor-patient relationship stuff. It's a good way to really pick on foreigners who are taking the step one exam, because in America we all know it's a big deal for doctor-patient relationship to be a very strong one, but in places like India or other countries in the East, it's not really that big of a deal. All right. So that's where I'm going to leave it off at now. We're done with all of our endocrine. We finished cardiovascular. Now in the next video, I'll start jumping into our gastrointestinal system.